Good morning. I see we're live. Hi, Dr. Rosensweet.
We are live, Carolyn Shapiro.
It's a good thing.
It's a good thing.
We're live, yes, it's a good thing, and that we're live is a good thing. And right here, I have questions for you. And as always, so appreciated that you take the time to answer them. Let me get started.
Well, let me just say, it's not like I take the time. It's an honor and a privilege, and it's part of, well, there's a term called dharma. It's part of the unfolding of what I came to Earth to do, one of the things. So I do appreciate your kindness in acknowledging that, but I would like to say I'm every bit a part of this from the inside. So it's not like, well, I take the time, it's like, this is very important. This is good stuff for me. So
it is, and it's really appreciated. A lot of fun, and oh, do we learn? Oh, yes, we do. So let me start us off with question number 1, if you're ready for me.
I'm ready.
All right. So, can estrogen cause anxiety and insomnia? I've been on my estrogen and testosterone the past 5.5 months, feel lousy, and my numbers are all over the place.
It's a not uncommon comment. And the goal, of course, in treating a woman in menopause with compounded bioidentical hormones is for the woman to feel good.
Mm-hmm. Mm-hmm.
And there's a lot of moving parts. And so one thing I learned is I started specializing in this 25 years ago is, oh my, every woman's individual and they have an individual balance and you got to get everything right. And there's a lot to it. And when a woman goes out to receive treatment, sometimes she's in the hands of someone who knows what they're doing. And a lot of times there can be a really good doctor or nurse practitioner, but they may not know what they don't know. And they're approaching it like what was traditional to approach women in menopause, which is, here, 1 or 2 doses, try this, you should be fine. And they don't know what they don't know because there was a big crimp put in the whole menopause medicine deal for fear. Fear was injected. And so a lot of people did not specialize. And so what I can say to this questioner is something's wrong. Something's wrong in how you're being treated. I don't mean to diminish the care or the deep caring that the physician or nurse practitioner can be who's treating you, but your situation is a very common one. Something's off. You got too much or too little estrogen. You got too much or too little testosterone. You may not have enough progesterone, and you want to get that DHEA right and your thyroid right too, as far as the hormones go. Because most often in a woman of perimenopausal or menopausal age, the hormones are the elephant in the room, and it's quite a process to get them right. Like in the menopause method, we spend a lot of time with a lot of consultations. In fact, women who join the membership, they have unlimited time with their provider because we know it's a piece of work and you got to walk it out and come up with this idea, adjust it, come up with this idea and test. And when in doubt, just for openers with you, I would suggest that if we did a 24-hour urine hormone test on this particular woman, we would not find her in the zone. Now, when she says blood tests are not, they just don't work that well, if at all. It so much depends on when you took your last dose and something called pharmacokinetics. And so 24-hour urine hormone test, not the 5-point, not use pee on to filter paper 5 times. Nope, that's not what I'm talking about. I'm talking about a 24-hour urine hormone collection. We could assess where you are, but you know what? If we were to take myself or one of our providers were to take a very detailed history on this patient, we'd ask a lot of questions that would relate to a lot of things. And it's most likely we would get a sense of what the issues are right now. Because if you do too much or too little, or I should have said too little or too much estrogen, you do too little or too much testosterone. These are the errors that are being made. You get wonky reports. And the main thing that I heard in that question was, I don't feel that good. So I can tell you what's going on. You don't have the proper amounts of estrogen, progesterone, testosterone, and DHEA. Something's off, or thyroid. So the deal is, we would like, you just need the next level of rigor and scrutiny and investigating your case, and you'll get there. I wouldn't get discouraged. This happens to millions of women because when they go out to find someone who really knows what they're doing, like if you wanted to have a knee replacement or you had diabetes, you could go out and find thousands and thousands of healthcare providers that really knew what they're doing and really could guide you into the proper zone. And, I could name that about so many specialties, but not menopause. Oh, no. The kind of information that's still being taught is very mixed. I very rarely come across an educational system where these folks, and yet the people who are doing the system they believe in it. So they think it's right.
Right.
Well, why would I make such an outrageous statement? Because I sooner or later, a lot of people who have had challenges find their way to me or our system. And we can see, they're using the inappropriate testing, or they're not using the correct estrogens, or they're not using the correct application methods, or they're injecting these things. And, there's all kinds of reasons. So don't give up. Like I've said on our beloved Facebook Live so many times, your job as a patient is to find a healthcare provider that, number one, you trust, and number two, really knows what they're doing. And, one of the screening tests is you can find out if they're doing 24-hour urine hormone tests. They've gone a long way. If they're not, with all due respect, or with not respect, I can't say that you're going to get the kind of results you want because they haven't gone deep enough. So contact us, but, read our book, download the book. Carolyn's made the book available on this Facebook Live. And you'll get an outline of what I consider to be really excellent treatment. And, I have very strong opinions. I think our method, or something close to it, is what women really need. And because so many women, I'm sorry to go on so long, but it's such a common question. So many women get involved with hormones and they don't get it quite right, and they get discouraged, and they think there's something wrong with them eventually. And, and I just want to take you back to the drawing board. Your job is to find someone you really feel good with, and you're getting good results. And you're going, oh my God, I'm myself again. I feel better. That's your job. Keep shopping. We shop for a lot of things.
Well, indeed we do. And to feel better is everything. Honestly, it really is. Thank you for that. Thank you very much for that. The estrogen causing anxiety and insomnia, I like to, if I may interject this, my favorite pages just from the beginning, 326, 327, where you can see dose determination and the highs and the lows and so on and so forth. So,
and thanks for bringing me back to that, because that was part of the question, which I wandered into the ozone there. Yes, estrogen, when you got too much estrogen, it is disturbing to them in a lot of different ways. And it can disturb your sleep, or too little estrogen can lead to major sleep disturbance. And too much testosterone can really cause it. Too much of any hormone. They're all so powerful.
Mm-hmm.
These are the strongest, most powerful biochemicals that are floating around in our body. And you get too much or too little, and it does not work.
You're right. Let me welcome in our Facebook users. Deborah, yes, will absolutely get you a copy for the book. Facebook user, Facebook, and these people have names, but they're coming up. So welcome to everybody being here. Very happy to have you. I'm going to move to question number 2, which I really like, and that is, what is DHEA, and why is it that some of us need it so much?
Well, it's, technically, how do you classify it? As a hormone or a prohormone, meaning that it becomes a hormone? Well, I don't think that's so significant as this. It is the most prevalent steroid hormone in our body. There's more milligrams of DHEA in our body than there is of all the rest of the steroid hormones. I'm talking estrogen, progesterone, testosterone. And so it's possible that we want to copy nature and pay attention to this one and respect this one. Now, on 24-hour urine hormone tests or even on blood tests, it's invariable that people's DHEA levels decline over time. And I've tested 1,000 women in perimenopause and menopause, and every single one of them does not have youthful levels of DHEA. And every single one of them gets into some super low levels of DHEA. Well, any other hormone or prohormone or biochemical in the body, if it gets too low and it's important, we want to replenish it. One difference about DHEA is it doesn't give direct symptoms of insufficiency like the other hormones do. Like, for example, when you get low estrogens, you're going to get hot. 75% of women are going to get raucous symptoms. They're going to get hot flashes. They're going to wake up with racing mind. Their breasts are going to shrink. They're going to get vaginal atrophy. Their bones are going to, on and on and on with low estrogen. It screams loudly for most women, not all women. Same with testosterone. You get low testosterone, you're going to get uncomfortable in very specific ways. And the same with progesterone, but not so much with DHEA. And DHEA converts in the body to, even though technically it's called an androgen, it converts primarily in a woman's body to testosterone or estrogen.
Interesting.
So it can go either way, but you're not going to get direct symptoms of insufficiency of DHEA. But here's the deal. Every single woman, as she goes into perimenopause and menopause, gets diminished hormones. And it's not a good thing. There's deep and long-term consequences, whether you have symptoms or not, to low hormones. And you don't want to be looking at a 24-hour urine hormone test and see a super low DHEA, as invariably happens, and say, well, I'm just going to disregard this because it doesn't give any direct symptoms. No. And DHEA, there's a tremendous amount of medical literature on DHEA. So anyone who dives into the medical literature sees the importance and value of DHEA. So even though you're not going to get direct symptom feedback, you want to get the DHEA not into excessive levels, but into reasonable levels. And just to let you know, because DHEA's got this unusual thing going on with it, you can purchase it over the counter. And you can walk into any drugstore, and sometimes they've got it right at the checkout counter. I've seen these DHEA. And here's what I want women to know. Don't take over 15 milligrams a day orally. Sooner or later, you're going to get into excessive levels of DHEA. And yet they've got 25 milligram and 50 milligram DHEA sitting at checkout counters. I think it's an FDA pounce ready to happen. I don't, sooner or later, the FDA is trying to regulate things into reasonableness as one of their functions. Sooner or later, it's going to be discovered that DHEA should not be sold over the counter because it's too easy to overdose. So if you're taking it orally on your own, don't take more than 15 milligrams. In our practice, in the menopause method, when we're very specific about this, what a woman will wind up taking, well, we love to stop. We love to start with topical DHEA. Anything you swallow has to go through the liver first, and it's acceptable with DHEA. Oral DHEA is acceptable. It's not acceptable with estrogen or testosterone oral to me, but it is with DHEA. But we have women on anywhere from 7.5 milligrams to 15 milligrams. And I'd say most women, eventually we oscillate them in because of testing to somewhere between 10 and 12.5. So just know, even 15 milligrams can ultimately result in too much over time. So DHEA, when you see vitamin D is low in your body, you want to take vitamin D or vitamin A, or you name it, anything low, you want to do it, but especially hormones. You got low thyroid hormone, you want to replenish thyroid. Oh boy, do you, because you're not going to like it when it's too low. Same with DHEA, even though it doesn't scream as loud symptomatically.
Well, she says, what is DHA and why is it that some women need it? Something we make in our body that diminishes.
Thank you. Thank you for taking me back once again to the beginning here. DHEA is either it doesn't matter. It's a steroid hormone, that's for sure, or some people call it a prohormone. It's made by the ovary and the adrenal gland. It's a steroid hormone like estrogen is, like progesterone, like testosterone, like cortisol is a steroid hormone. And there's a lot of it. It's the most, when you measure DHEA, it's present in the most milligrams in a woman's body. So it's not, do some women need it? I can tell you, by the perimenopausal time, every single woman I've ever tested is low or lowish in her DHEA. And by menopause, every single woman, sooner or later, those DHEA levels go way lower than I like to see, or what I would like to have in my body. Men need it too. So all women need DHEA, and all men need DHEA, not some. Because we're just not producing at the levels that are that really promote health.
Right.
So I like to copy nature. We don't have to restore youthful levels. We don't have to become 21 again, although there are exceptions. They're rare. Some women really need robust levels of hormones. But we don't want to see these levels super low. Not me, not in my body.
No, right, understood.
I take DHA. Men need a little more DHA. I take it every day.
That's it. Yeah. Well, I guess a talk needs to be had with someone.
Then, to really understand, if you go into our book, you're going to see these biochemical roadmaps.
Mm-hmm.
And what you're going to see is your body takes what you eat, and through magic, so to speak, it converts what you eat into what you need for the body to work beautifully. And what you see is that these hormones are made out of, well, interestingly enough, cholesterol. And then cholesterol gets converted to something called pregnenolone, for example.
Mm-hmm.
And pregnenolone gets converted. And DHEA is right there in the central biochemical roadmaps. And DHEA is produced in the ovary and the adrenal, and DHEA becomes estrogen and testosterone. Don't leave DHEA out of that mix.
Mm-hmm.
I wouldn't.
No, and thank you.
You can see it in the book. You can see it in the biochemical pathways.
Again, Happy Healthy Hormones. It's there. It's downloadable. I will get with you. Make sure everybody has that link right up front.
And someone is asking, in fact, hi, Joanne. So could someone assume that low DHEA is due to adrenal issues? No. Because DHEA is produced in abundance in two different glands, the ovary and the adrenals. So the ovaries start declining over time. Your peak ovarian hormone output is when you're 20, and then you just gradually decline until you precipitously decline when the ovaries stop working. And the adrenal glands, DHEA, oh yeah, they sure do. So you can get low adrenals, low DHEA from two things that diminish over time, both the ovary and the adrenals. But the bottom line is this: All of us peak out at our hormone production in our 20s, early 20s, and we gradually decline. DHEA can be tested in blood, but it's where it becomes unuseful to test DHEA in blood is once you start treating a woman. Then it's the 24-hour urine is going to give you the accurate results. Now, when you test DHEA in the blood, you don't ask for DHEA. You ask for DHEA-S, because that's how DHEA appears in most abundance in the blood. It's transported in the blood, like all these steroid hormones are, and it's the DHEA sulfate, really. It's the DHEA-S. That if you're going to get a blood test for DHEA prior to getting treated, if you get treated, I don't see the value in blood tests for hormones. So yeah, there's some stuff about DHEA.
Yeah, well, it's really interesting, DHEA, because often we talk estrogen, progesterone, testosterone, and DHEA. Those for you.
And there's another good question. If you have slightly low testosterone but low DHEA, should you treat low DHEA levels first, or can you treat both together? It depends how old you are, but the bottom line is I always treat the individual parent hormones. Like, for example, if you look at the biochemistry, I could say, oh, you're in perimenopause, you're low in hormones, your ovaries declined majorly, you're in menopause majorly, so your ovaries are no longer producing. I know what I can do biochemically. I'll just give you cholesterol. Because after all, cholesterol gets converted ultimately to DHEA, testosterone, progesterone, estrogens. No, won't work. I wouldn't advise it. Don't take extra cholesterol and expect to produce steroid hormones and recover. Well, I could give you pregnenolone. That's the first active biochemical in that. If you look in the roadmap, the biochemical roadmap, yes, but we can't control what it becomes. Now, we do give pregnenolone for other reasons, for its direct effect on cognition. But, well, why don't we give DHEA? It can convert to either estrogen or testosterone. Yeah, but we can't reliably predict what it's going to convert to. So I always say when a woman's in the perimenopause and menopause, be accurate. Give actual biased for estrogens, actual progesterone for progesterone, give actual testosterone, and give actual DHEA. And tweak that stuff until you get a 24-hour urine hormone test that shows you right in the optimal zone. It exists. That optimal zone exists. We know what it is. And you test by 24-hour urine hormone test, and that's how you find out. So I would not give DHEA, for example, to correct testosterone, because you don't know that it's going to correct testosterone. It could elevate your estrogen, and that's not the way to elevate estrogen.
Right.
So we like to see all these steroid hormones on 24-hour urine hormone tests in the optimal zone.
May I throw this question in? It says, hello, Dr. R. and Carolyn. What would cause DHEA-S levels to be elevated without taking supplemental DHEA?
Well, I'm going to assume that that situation can exist. The most common one is you're stressed. And you still got healthy adrenals and ovaries. So it's more likely that a young person is going to get elevated DHEA-S. And the first thing the body's going to do with the stress response is it's going to produce a special biochemistry that will enable us to fight or flee. And what we think of is the vanguard of the hormones, because they're the most powerful things that can help you fight or flee. We think of adrenaline and cortisol. They are at the head of the pack in the biochemistry of the fight or flight syndrome. But they're not the only thing that are recruited. Heck no. Testosterone, estrogens, DHEA, these things are all recruited because they're energizing, powerful biochemicals. And that's one of the ways that when women are in their 30s or their 40s, or certainly by their 50s, women and men, we wind up with low DHEA, we wind up with low testosterone, and women wind up with low estrogens and testosterone and DHEA. So, yeah, that's how it happens. And now, would you take me back to the original question again? Because
Well, you answered it well with stress. Stress plays a very important part.
how can it be elevated? I'm sorry, Carolyn.
Yeah.
It's how can it be elevated? It's the stress response, most likely. Now, there is a genetic elevation. We discovered that, and it's pretty rare. And I've only seen it in males. Like if you look up into about Italians, you'll see sometimes they have a propensity genetically for elevated DHEA, but doesn't matter if it's a little elevated. Sooner or later, it's
Yeah.
going to come down. So there is a genetic possibility that you're going to produce a little more DHEA than others, but it's no big deal. That's not a problem.
Oh, that's a good
The
thing.
main reason is stress.
Yeah.
I personally have never seen an elevated DHEA level in a woman who's 50. Never seen it. So I'm assuming that when there's an elevated DHEA, that this is a younger person, or there's that rare genetic thing, but it's not a problem. If I would like to do one caveat, and this is why you want to have an expert. There is some situation, and it's an adrenal producing tumor. And in my 25 years of treating women in menopause, I detected an elevated cortisol level, could be an elevated DHEA level, and it didn't look right to me. It looked like it was too much. And we did a CAT scan of her adrenal gland, and sure enough, she had a benign tumor, and that tumor was caught at a very early stage. So I could imagine a case where DHEA would be elevated in an adrenal tumor. Very rare.
Yeah.
But I've seen it. And here's another common reason that it's elevated. People are taking something called adrenal support or adrenal supplements. So I had one woman that when we did the 24-hour urine hormone test on her, we saw high cortisol on her. And I thought, oh boy, here we go. Let's do another CAT scan. And then I asked the other question. I said, are you taking any nutritional supplements? Get the bottles, put them out. Let me see them. And sure enough, there was adrenal support. And what you don't know about some of these supplement companies, not supplement companies with integrity. And there are many supplement companies that have tremendous integrity, phenomenal rigor in the quality of what they're producing.
Yes.
And there's other supplement companies out there that are the Wild West. And they're throwing things in these supplements to make them powerful and make them felt, and they're not reporting it. So it's been known for years that occasionally these supplements have got actual hormones in there. And people do feel the effect of them, but they don't list them because that's illegal to not list something that you're sticking in a supplement. So that's a rare thing. But sure enough, this woman, I saw the label, and when I saw that it was a type of adrenal support, I went, and it wasn't on the label. I went, we better check it out, and let's have her stop taking the adrenal support. The glandulars, they're called glandulars. They're desiccated glandulars.
Yes.
And sure enough, she stopped taking the glandulars, and all of her hormone levels went back into what I would expect for her. So buyer beware. Or as I always say to you, caveat emptor.
Caveat emptor.
Although, Carolyn, I'm not really sure what that means, but at least I'm making it up.
It sounds good.
We don't often speak Latin to one another.
I wish that there was a Latin class because I love Latin. I think it's really good. Anyway, well, thank you very much. It's a good answer. DH is a little confusing for some of us. So I'm going to move on now to question number 3. And this one is asking, is there a certain amount of progesterone we need to build new bone? I take 20 milligrams per day and wonder if that is enough. I'm also wondering if it has to be up to 100 or 200 milligrams to be effective, which is hard for some of us women, but maybe 20 milligrams isn't enough.
I love this question. And it opens the door to a very common issue that needs to be addressed with significant rigor. There's that word again. And it's called health of bones. And progesterone is a player. And progesterone is the only biochemical that I know of that supports the function of osteoblasts, which are the cells in bone which actually lay down new bone. Progesterone definitely relates to bone. But let me take it from how it's actually approached in women patients.
Okay.
When we see in the menopause method, and many physicians, nurse practitioners, and healthcare providers approach it this way, we're looking at a lot of details in a menopausal woman, and bone is one of them. And one thing is, if I see a woman has been 5 years without hormones, like her last period was 5 years ago, and she hasn't had hormones for 5 years, she's got osteopenia or osteoporosis until proven otherwise. These hormones really make a difference. Well, in the menopause method, and I assert it should be something in every method, is that on entry, a woman in the perimenopause or menopause, we get a bone density test as part of what we do, normal procedure, because we're not going to get symptoms of bone loss very early on. Later on, we can get symptoms of osteopenia or osteoporosis. A woman could fall in what seemed like a minor fall and get a fracture. Whoa, that should not happen. When I hear fracture in a woman, I immediately am tuned into, yeah, well, how old is she and how severe was the blow? But we approach it from a different angle. Part of the entry process is we get a bone mineral density. If we have a normal bone mineral density or some osteopenia and the woman is just entering menopause, the hormones are going to take care of her. If we see significant osteopenia, we're going to want to make sure that every one of the moving parts that relate to bones is up to speed. If she has osteoporosis on that initial bone mineral density, we're going to burrow into that with great vigor. Let me tell you the moving parts, because there's lots of things that relate to bone health. At the vanguard, what matters most to bone health are the hormones. And I'm talking about a lot of them. Almost all of them relate to bone health. I put at the top of the list estrogen. This is one of the major reasons of the bazillions of reasons to replenish estrogens as early as they start to decline, which is in the perimenopause. You can count on it. Estrogens decline. Your peak estrogen output is when you're 20, and from that time on, it declines. And then it really declines when the ovaries stop. So estrogen is so crucial to bones. Progesterone is too. And you can be certain that progesterone is declining maybe even deeper and more profoundly and earlier than the estrogen is. So the moral of the story is replenish that progesterone. And 20 milligrams topical in a perimenopausal woman that's having regular periods, that's a good thing. And of course, insufficient progesterone will have symptoms very often, relate to sleep and mood. Now I'm going to go back to what are the moving parts in bones: estrogen, progesterone, testosterone. Oh God, it relates to bone. DHEA relates to bone. Thyroid relates to bone. And all of these hormones are diminished. So when I see actual osteopenia or osteoporosis, we're going after the whole 9 yards there. There's another major player. Bone, I mean, some people have heard that we're constantly recycling our cells. Like the turnover rate for red blood cells is just phenomenal. You don't have the same red blood cells in your body that you had 3 months ago. They've been broken down, recycled, new ones have been replacing them. Well, the period of replenishing in bones is not as rapid as replacing red blood cells. It's 7 years, actually. But still, bone has very active metabolism. It's constantly being broken down by a process called by osteoclasts. They're breaking down. They're cells that are breaking down bone so that new bone can be put in its place. That's a great approach to things. That's called, wow, keep on producing new bone, break down the old, replenish with the new. Wow, how radical a process is that? Well, estrogen relates to those, and estrogen slows down the breakdown of bone properly. And progesterone, once again, stimulates the production of new bone. But what's bone made out of? If it's going to break down, you got to have the raw materials that bone is made out of. And it's primarily minerals, especially calcium and magnesium, and it's protein. That's what bone is made out of, mineral and protein. So you got to have adequate protein in your diet, and you got to have adequate minerals. Oh, here's the elephant in that room. It doesn't only matter what you're eating. It matters what you're capable of digesting, and protein and minerals are the most challenging things you take in through your mouth to digest and assimilate. So you got to have a healthy gut. You got to have healthy digestive juices. And guess what about adults? We don't have the same level of digestive juices we had when we were kids. So many of you have noticed that you're not quite digesting like you did when you were 20, when you didn't think about digestion. But when you're 40 or 50, you might think, gee, I still feel full and it's 2 hours after I ate. What the heck is going on here? Or I got reflux. What the heck? I'm lying down in bed. It's 3 hours after I ate and I've got esophageal reflux or GERD. Yeah. And I got a little acid burn here. Yeah, because you didn't digest your meal, for one thing. So there's many folks in the world of functional medicine that are taking digestive enzymes and extra hydrochloric acid, because both of them are needed to digest and assimilate protein. So if it's getting a little dense, well, bone is dense. You got to attend to the whole 9 yards here to produce healthy bones. Here's another thing. Bones, stress metabolism, we produce acid. It's acid producing. Stress biochemistry is acid producing. We have a chapter on bones in the book. Read that chapter. And acid is not acceptable for the body. Excessive acid is not acceptable. Mm-hmm. So our body has these wonderful compensation mechanisms to make sure that we stay in a very narrow, not too acid and not too little acid range. And it's heavily regulated. So the very first line of defense, if you're producing too much acid, is you bind it up with carbon dioxide and, with bicarbonate, and you breathe it out as carbon dioxide. That can immediately buffer, it's called, excessive acidity. And then there's second and third lines of defense against excessive acid, and ultimately the minerals. They work really well to buffer. Well, where is your reservoir of minerals? It's in the bones. It's in them bones.
Them bones.
Them bones. And people who are constantly, consistently overstressed and producing excessive acidic metabolism, they're eating into those bones. And that's the one way males too. Excessive stress. Or, my God, the very hormones that are at the vanguard of the fight or flight biochemical response to stress. Oh, cortisol. Guaranteed to, quote, melt the bones. That's one of the long-term adverse effects of taking steroid, cortisol or prednisone or any of those things. It'll melt the bones. It'll give you kidney stones. It'll melt the bones so much. So what am I saying here? Eliminate all stress in your life. No, wrong. Wrong answer, doctor. Human life has built-in stress, and it's good for us. It's part of life. It's we got to increase our skills in how we respond to the stress of life, because you
Right.
eliminate one stress and like whack-a-mole, another one's going to pop up. So your task is not to listen to that crazy statement of eliminate all stress. It has a wonderful function for us in this life, but it does matter that we increase our skill set so we're not constantly triggering the biology of the stress response. So if you get emotional tools and mental tools and life choosing tools, you can eliminate the biology of the stress response, or certainly moderate it. So there's a lot of moving parts with bones. So we want to attend to all of them because they all matter. Now I'm going to get down to progesterone. Well, any woman that we're treating in perimenopause or menopause, we're going to want her to have optimal progesterone levels. And we can pick up on that through lots of different ways that we evaluate women, including ultimately the 24-hour urine hormone test. So exact milligrams, the way we determine progesterone in a woman really matters. Like, for example, progesterone relates so much to sleep that we like to give the right dosage of progesterone for sleep. So with progesterone, like all hormones, we start low, we have her take it at night, we gradually increase, and progesterone is so calming and relates so much to sleep that for so many women, if they take too much progesterone at night, they wake up in the morning groggy, like they've been overdosed with a sleeping pill. Okay, that tells us that we've gradually increased the progesterone until she got groggy the next morning. That means we got too high clinically. So we back it down so where she's not groggy in the morning, she gets the sleep benefit. This is how we determine progesterone best case. And we start out with topical progesterone, but we can, because progesterone, there's so many milligrams of progesterone in a woman's body, we can't often get the topical as concentrated as we want for some women, so we'll switch to oral. And we keep jacking that up, especially with someone with osteopenia. You want to know how much progesterone? We jack up that progesterone at night until that woman wakes up groggy.
Got it.
And then we back her down.
Got
So
it.
what we do in the menopause method is we start women, we give them 2 different bottles of oral progesterone if we're gone so far as to get the high doses. If the topical, we can't get them high enough. Some women, they take the drops of progesterone, they get up to 5 or 6 drops at night and they wake up groggy. And so we're obviously getting the right amount of progesterone into those women. But when we so we start out with the topical progesterone. And some women we're going to get groggy. But some women we got to go to higher doses, so we have to go to oral, and there is special sleep benefit with the oral. There's plenty sleep benefit with the topical, but when we really have sleep issues, we've got to replenish the estrogen plus the progesterone.
Yeah.
Both count. But we'll jack up that progesterone. What we do, we give a bottle of 50 milligram capsules of progesterone, microdosed, compounded by a compounding pharmacy because they're not commercially available. And we give a bottle of 25 milligrams. And we start most women on one 50 milligram capsule a night. And we'll try that for a couple of nights. And if she doesn't get sleep benefit or she doesn't wake up groggy, we'll have her add a 25 milligram. So now she's at 75 milligrams per night. And we see what happens. Does she sleep well? Does she wake up groggy? Oh, she's not waking up groggy and she's got osteopenia? Jack it up. We'll have her take 2 50s, which will bring her up to 100 milligrams. And we keep going until the woman gets groggy. 100 milligrams, 125 milligrams, 150 milligrams, 175 milligrams. Most women in my practice come in somewhere between topical will work, or they come in between 75 and 100. That's the most common. But some women need 125 to get groggy the next morning, 150, 175. Someone with osteopenia, we want to take them to groggy because you asked how much is the proper progesterone. We want to take them to groggy, to overdose, then back them up to where they don't wake up groggy. That's how much progesterone. Now, here's another exception. We love to give progesterone at night only because it really helps with sleep. And some women, when they take progesterone during the day, can get groggy.
Mm-hmm.
But there's some women who have anxiety. And it's different. They're strong women. They've been riding the waves of life. They know what stress is. They do fine, like we all do. We can feel stressed at times. But then they go into the perimenopause and they're starting to feel anxiety. Now, some women feel, and men feel anxiety earlier. This is a different thing. This is for women who haven't really considered themselves to have anxiety.
Mm-hmm.
But then they develop anxiety in the perimenopause. And here's how I learned it. I had patients come back to me for their usual follow-up consultation. And they would say to me, I really love that progesterone. It calms me down so beautifully at night. And I sleep so much better along with the estrogen. And I really love the calming effect with progesterone. Can I take progesterone during the day? They would say to me. And I'd say, well, yes, you can. Just be careful that you don't take so much that you get groggy and it interferes with your ability to drive a car or operate a crane or whatever you're doing or fly an airplane. Don't take too much. You just got to watch out with progesterone during the day. And they would say, well, I already have been doing it. It feels great. This is how I learned how to practice. The women taught me how to do this stuff.
Sneaky.
And so we highly recommend for women who have developed this mysterious anxiety that it's not their nature, or it's not their deal when they were younger, take progesterone during the day also, but start lower and just find your, I'm getting a little blurry here, dose, and then back down. So how much is the proper dose of progesterone? Determine it clinically. And if you've got osteopenia or osteoporosis, we want to take you to the limit. We want to take you to the sky. So we want to take you to groggy and back you down. And then you'll test out. If you're taking oral progesterone, it's challenging to interpret the results anyway, because 80% of it never reaches your full body. It goes through something called first pass to the liver, and we describe that in the book.
Right.
So testing progesterone when you're orally, we're not getting accurate levels. There is another thing around progesterone. We certainly want enough progesterone to balance the estrogen. And what's another marker of that you don't get an excessively thick endometrial lining? But I'm getting really technical. I'm getting really technical because this is a technical topic. And that's why I keep returning to the same thing, saying to women, your job, you don't have to go to medical school. Learning a certain amount, like what we offer in the book, can be helpful, but you don't need to. Your job is this. Find someone who loves this stuff, who knows the many million moving parts around bone, around sleep, and really knows their hormones and really knows how to test you. That's your job. Know enough that you know how to check people out. Because you're going to run into a lot of dedicated, devoted healthcare providers. I love them. This is my tribe. Janitors in hospitals to all the way to neurosurgeons and everyone in between, desk clerks. These are dedicated, for the most part. Yes, there's some grumps. Yes, there's some bad bedside manners. Yes, there's even some weirdness. But I've been in this for 50 years, and I can tell you, 55 years, and I can tell you there's some precious, devoted, loving, caring folks who've given so much to humanity, if they're sometime at their own cost.
Yes.
However, that doesn't mean they're experts at menopause. And we don't know what we don't know. So they could be excited about treating folks because they can get some good results with a small number of women. But at any rate, your job is go find the ones who care about this so much they want to specialize in it.
Mm-hmm.
They've really taken on the educational and the mentoring.
Mm-hmm.
In every field of medicine, there's specialties.
Mm-hmm.
And you don't want to go to a family doctor if you've got a major heart issue. You want to go to a cardiologist. If you need a knee replacement, you don't want to. I mean, in the old days, general practitioners used to set bones, fractured bones. Even when I was a young kid as a doctor, there were family docs were still setting bones. That's not what you want. You want an orthopedic surgeon who's had 2 years of surgical training and 3 years at minimal of orthopedic training and has set hundreds of bones under the supervision of the elder mentors. And really, and they're dealing with hundreds of patients and they're being mentored every step of the way. That's how they learn this stuff, patient after patient under guidance. The medical training program is beautiful. It's a wheel that does not need to be reinvented. Well, you want the same for menopause because you're dealing with hormones. And if you find some of the things that I say are rather complex, because they are, so you want to really get it right, find yourself a specialist. Join the menopause method.
Oh, absolutely.
And find someone who really knows what they're doing. And there's a lot of ways to tell if they know what they're doing. And the simplest way is, are they doing 24-hour urines? If they're not, they're trying to find their way. And they've been, anyway. So
Yeah.
God knows what that question was.
The question.
Osteoporosis.
No, you've answered.
Osteoporosis. There's a lot of, what's the right progesterone dose? If there's osteopenia or osteoporosis, jack it up. And we do that anyway. It's part of a normal process. We want to get enough woman a robust amount of progesterone because it's so good for her mood and her brain and her bones, not to mention her endometrium and her breasts and balancing estrogen. There's 100 times more progesterone in a young healthy menstruating woman than there is estrogen. You think whoever created, I'd like to meet them. I think I will someday. I don't think we want to talk about that right now. Nature in quotes, believed that progesterone was really important because it put 100 times more progesterone in a woman's body. So and progesterone, you can give a lot of progesterone. You don't want to give it too much estrogen. You don't want to give too much testosterone. You can get away with giving a lot of progesterone. And you won't get away with giving too much because the woman's going to get symptoms of overdose. She's going to get groggy and wonky and wobbly and fainty, and her gait's going to get funny and her speech's going to get slurred, everything, because it's the great conversation. I apologize for going on a little long there, Carolyn, but
no, it's fine. I have one more question that
sure.
I want to get, and thank you for that in regards to progesterone. It's a big one, and I know that. This woman is taking estradiol 1 milligram gel, and she's saying that she's lightheaded and she can't sleep. She has calcified blood vessels in her brain. They bled after she had a stroke in 2015. Her gynecologist said that estradiol could stir, them up. So she's very concerned about this. She can't get an appointment for 3 more weeks, and she's not sure if she should continue on with the estradiol or not. And back to progesterone, if she should be taking progesterone.
Another excellent question. And the proper answer to this is how complex treating women in menopause can be. These details matter. And she's had a stroke. Now, there's 2 types of strokes. One is the bleeding type and the other is the clotting type. And what we're most familiar with is that oral, that means you take it by mouth, estrogen is known to provoke coagulation. And so a woman who is normal coagulating can become hypercoagulable and have more of a propensity to form a clot.
Yeah.
Taking oral estrogen. This is well known. Where did we learn it strongest? Young women on birth control pills. Although it was an uncommon side effect, adverse effect of birth control pills, some women would develop clots in their lower extremities called thrombophlebitis. Young women on birth control pill. And some rare ones of those women, that clot would break loose and go to the lungs. Pulmonary embolus. These are known complications of oral estrogen, whereas topical estrogen does not do this. And yet, there's a couple technical issues here. Like, for example, we had a young woman, totally classic menopause. I'm doing an intake, and where I'm reviewing her questionnaire with her, and her mother and her grandmother have a stroke, have a history of stroke. And I'm not going to put her on oral estrogens anyway, because there's only one patient in my whole history that I put on oral estrogens. It was because the woman could not comply with the topicals. And, truth be known, that was my mother in her late 80s. I always put women on topical estrogen, and a lot because of that coagulation issue. Not the only reason, but there has been 2 cases in 25 years that young women, I was taking an intake history, and they had thrombophlebitis when they were put on the birth control pill. And I said, well, great, but we can still treat you in menopause with hormones. So we're going to give you topical hormones. And both of them reported that they were having discomfort in their lower extremities, like when they had their thrombophlebitis. So we stopped the topical hormones. The thrombophlebitis went away. I mean, the discomfort went away. It wasn't thrombophlebitis. We started them again. It came back from topical. So you never say never, even though the medical literature is very clear that it's oral estrogen. You always respect, when you're giving a woman hormones, that you could be affecting her coagulation mechanism. So back to the woman whose mother and grandmother had a stroke, and here she is going into menopause, and we're thinking about treating her with hormones. Well, I'm not going to give her oral estrogen, so I'm not going to increase her coagulation mechanism. However, I went ahead and ordered a very sophisticated and expensive coagulation profile from a very common lab in the United States, because they know how to do some very sophisticated coagulation profiles. And before we're going to treat her, we're going to see where her coagulation is. Is it perfectly balanced? She's not hypercoagulable, or she's not too easy to bleed. No, she's spot on. And if she's hypercoagulable, we have many nutritional supplements alone can back that down to where she doesn't have to. So we're going to deal with her coagulation propensity first. And then we're going to treat her. So we're going to keep her a little bit on the bleedy side. Like, I can give a lot of women a certain amount of omega-3 fatty acids and vitamin C and vitamin E, and they'll start bruising on the back of their hands because their propensity to coagulate has diminished, and they're bruising because they bleed too easily. And anyone that I have concern about arterial sclerosis, and this woman has arterial sclerosis, I don't want them to coagulate too easily. So one really crucial thing, if they're seeing arterial sclerosis in this woman's brain, oh my goodness, I have to complete really soon. They're seeing arteriosclerosis in some woman's brain. Hang on a second. I must set up the logistic for this consultation. I'm going to go on. Sorry. Okay, I think I'm set up. So just bear with me for a minute. We have a technical issue here. There's a doctor calling in, and it's very important that I speak to this doctor.
Of course.
And yet the question is so important that...
I mean, I certainly can bring it up, number one, next interview for sure, if you want.
Hang on a second. Thank you for the logistics. I apologize here. So we need to pay attention to coagulation, and every woman in the menopause method is going to be evaluated for that in some way or another. And if there's anything in the history that suggests that coagulation could become an issue, we're going to deal with it with very sophisticated testing. Yet another reason that we want you to be working with experts in this field. It matters so much. I think that's the short version. I think, Carolyn, we might want to start out next Tuesday.
Yes, I've got it.
I'd like to elaborate on this one because it's such an important one. And everyone, I apologize. I have to make a fast exit here, as I've got a doctor that it's important for me to deal with. So I am going to sign off.
Thank you, Dr. R. Everybody have a great weekend. We're reachable. Many blessings and have a really great day.
All right, Carolyn, thanks so much. You have a great weekend. And to everybody else, see you soon if you want.
See you on Tuesday.
Bye-bye now.
Bye.